Good afternoon, everyone. First of all, thank you for joining us this afternoon for our presentation on the 2021 CPT code changes. My name is Rachel Pagliano, and my co-presenter is Susan Rohde. And she and I have been working in healthcare coding, compliance, revenue cycle related roles for over 20 years. And we're both senior managers with Eide Bailey and work in the revenue cycle area of the firm. So we have quite a bit to cover today. Just a quick overview of what our presentation is going to entail. So we have 329 total changes that the AMA notified us of a couple of weeks ago at the AMA CPT Symposium. And that breaks down to 206 new codes, 54 deleted codes, and 69 revised codes. But let me just say that 63% of the changes relate to new technology. So the AMA is really expanding into making sure that there is codes available to utilize for the new technology that's coming out and new ways of doing things. There's also continued expansion of the proprietary lab analysis section. So those are the PLA codes, which we'll talk more about in a couple of other slides. And then additionally, there's new codes, some in fact already implemented due to the COVID-19 public health emergency, but we'll still touch on those. And then of course, the evaluation and management coding and documentation changes. So overall, we're going to be going through each of the chapters within CPT where changes occurred, but these are going to be more of a high level overview. So we encourage you to review these sections of the CPT in more detail. And as you go through these changes, we also recommend including the clinicians at your organization that these changes pertain to, the providers and the clinical personnel, also along with coding, compliance, practice managers, charge master coordinators, revenue integrity, and patient financial services as appropriate. You want to make sure that your charge master and fee schedules are updated with the new codes, as well as any electronic preference list that you have in your EHR and your charge tickets, both electronic and paper. You want to make sure that those reflect any of these changes as well. So let's start with the COVID-19 testing related codes. Most of these codes are already familiar since the AMA fast-tracked their approval starting last spring. There's a lot of technical lab terms on this slide, and I'm not going to pretend to be a lab tech. So, and even the AMA during their presentation with us acknowledged that the terminology is confusing. So because of that reason, they added a great deal of information at the beginning of this section in CPT. So we highly encourage you to read through that portion of the CPT manual. And the AMA website also has some additional tools and some spreadsheets that relate to these codes. And there's a CMS MLN from September 24th that became effective on October 1st. And that's also a really good reference for the reporting for from a Medicare perspective on these particular codes. So we've had just starting with the beginning there with the very first nucleic acid PCR testing CPT code. That one has been around since the spring. And CMS issued their HCPCS codes for those lab tests as well. Later on, we received the multiplex codes, which would allow the test to be performed for not just COVID-19, but also for other viruses such as influenza A and B, or RSV, or both. Also, we have antigen testing, and really the main difference is that the nucleic acid test is going to be testing for like the DNA or the genetic piece of the virus, where the antigen test, it's less expensive and it's a little bit quicker result oftentimes, and that's testing for the protein. So it really depends on what is being tested on how you would choose the appropriate testing CPT code. And so we highly encourage you to talk with your lab personnel and really have a clear understanding of what testing kits are being purchased, what they are testing for, so that the appropriate CPT code can then be built in the lab system, as well as in your charge master, and then ultimately build out accordingly. So there's a great deal of codes here listed, and I won't go into detail on each and every one of these, but again, these are laid out in the CPT manual in more detail on the use of these codes and what they are actually testing for and the method that's being used. The antibody tests are another section within this related to COVID-19, and that is going to test for when a patient has had has already had the virus, and it's looking for the antibodies that show that they'd already had the virus. So there's a couple different antibody tests, and I just wanted to mention too, and I forgot to put it actually on the slide, but there's a couple different, the 86328 is a new child code that's specific to the antibody testing, and then 86769 is another antibody testing code. But then the additional new codes, 86408, that is more specific to a neutralizing antibody test. So again, it's about the terminology of how they're conducting the test and then what they're actually testing. So the PLA codes, which I'd already mentioned very briefly, these are the most specific, and they are particular to the actual manufacturer of the testing kit. So you would use these codes instead of a category 1 or a category 3 code if they accurately describe the test that's being performed. And I just listed some common examples. This is not an all-inclusive list of some of the tests that are out there. BioFire is one. Mount Sinai has a test. So these are things then that when you're having these conversations with the lab, make sure you know what they're purchasing, what the name of it is, and the full name of it, because sometimes they're very similar in name, but they have a little bit of a difference. And I would also caution you that the vendor may steer you towards one of these codes, but we want to double check and make sure that it's the correct code. And at the end of the lab section in CPT, all of the PLA codes are listed so that you can see the entirety of that list and what all of the brand names are that are associated with each code. So you'd want to double check what the vendors share with you. And then lastly, there is the supplies and materials code 99072. And there are specific guidelines in CPT that describe the use of this code. And that CMS MLN that I mentioned a few moments ago, they also give information on the use of 99072. So I would check both resources because you do have some payer-specific guidance there as it relates to Medicare. And then you'll have other payers that may adopt the AMA codes, or they may follow Medicare. So it's a matter of checking both, actually. All right, so we're gonna move on from COVID for a little bit and get into some of the other sections of CPT. So we'll start with cardiology. So the biggest thing in this section of CPT is the new codes that were developed for external extended ECG monitoring. So we've had the Holter monitor codes around for quite some time, but these codes allow for monitoring that's over 48 hours and actually up to 15 days. So the AMA found that clinical studies had shown that this type of monitoring was detecting arrhythmias, and they felt like this new technology warranted a set of CPT codes. So with that, they also did some revisions, and there's just one small revision there that they moved from it was just referencing a category 3 code. And then the rest of the codes are category 3. So if these are anything, and I'll just say this regarding all of the category 3 codes, if there are things that your organization is performing, make sure that that don't have a category 1 CPT code, make sure you reference the category 3 codes and see if there's a code there for your utilization. So really the ECG monitoring was the big change in the cardiology section. So interventional cardiology, there are 5 new category 1 codes, and the first is the atrial septostomy codes. So they actually developed these codes to replace some deleted codes, which I have noted below in the slide. And they felt that they needed new codes to provide more relevant and updated code language for this type of procedure. They also developed new codes for the percutaneous ventricular assist device insertions. So these codes reflect the right heart insertion method or way of doing the procedure and removal of the device. And no code had existed prior to 2021 to describe the right heart insertion. So with that, then they had to revise the current VAD insertion codes and reflect that those are for the left heart insertion and removal versus the right. And then they also updated the description of 33993 to reflect the repositioning for either the right or the left heart device. And then because of these new codes, then we have the deleted, the old deleted atrial septostomy codes. And there is one new category 3 code for an implantation of intraarterial shunt. Interventional radiology has one new category 1 code, and it's a code bundle, which we've seen the AMA moving towards more and more with these bundles, and it really incorporates all of the guidance that might be associated with the procedure. So this is a lung biopsy CT guided. So it is one code that incorporates both of those components. And so therefore they deleted the existing code 32405 because now 32408 covers it, and there's no need to keep this additional code. There's 3 category 3 codes in interventional radiology, and I have those listed there. And again, we just want to make sure that if you are doing any of these types of procedures in your organization, check the category 3 code listing. In the radiology section, the biggest change here is the screening CT of the thorax. CPT 71271 was developed to report the low dose CT for lung cancer screening. So I know that that's probably a pretty highly utilized procedure in most organizations. So it's good that we have this code. And with that, they did some revisions to the current codes by adding the term diagnostic, so they can distinguish that set of codes from the new screening code that they just developed. In addition, there is a physicist code, and this would just be to report the work that's performed by the physicist for dose evaluation. And there has been a code for radiation oncology and for physicists to apply that code in that setting, but they haven't had a code that can also that they can also report for dose evaluations in the diagnostic or therapeutic endovascular procedures. So this is a practice expense code only. This is really reflecting the work by the physicist that's employed by the facility. So again, this is just covering the screening CT versus the diagnostic codes that were already in place. And then I was talking about the physicist work and the code that was developed there. And then we also have one deleted code, and that's an ultrasound study follow-up. And the reason that this was deleted is they found that it was being incorrectly reported, and that they didn't find a need when they surveyed to keep this code, so they decided to remove it. And there's quite a few new category 3 codes in radiology, but they're really related to just 2 sections. MRS, which is magnetic resonance spectroscopy services, and then breast computed tomography. So there's a list of codes there for those 2 areas. So on to orthopedic surgery. So this one seems like this was a long time coming, but here is a guideline revision for arthroscopic removal of loose bodies. So now CPT has defined the threshold of the loose body size for arthroscopic removal. So in that guidance, and you could read that in its entirety, but the nutshell is that you would code for the loose body removal when it can only be removed through a cannula that's larger than the one that's used for the specific procedure that's being performed. So either it's through an enlarged arthroscopic portal or it's removed by a separate incision. So that would be the information that you'd be looking for in the operative note on when should we be looking at coding in addition for that loose body or foreign body removal. So this would be a good conversation to have with your surgeons to make sure that they're putting this documentation into the OR record so that you can code for that. They also provided some additional information for the shoulder debridement codes, 29822 and 29823. And they've basically defined that there's the number of discrete structures being debrided. So 1 to 2 is a limited and 3 or more is extensive. And they also provide some examples in that section of CPT. And again, this could be a good conversation with your surgeons to ensure that you have the detailed information in the OR report so that you can code for this. And there is a new category 3 code for humerus lengthening as well. Plastic surgery, really the main piece in this section is the new guidelines for mastectomy and breast reconstruction. There was a lot of information provided, and it really had to do with new techniques and new ways of performing this type of procedure. So they revised 16 codes in this section. And I won't go through every revision, but this would be an area that you would really want to read through in detail, understand what your surgeons are typically providing for their patients, and which could be any one of these things, and having a clear understanding of the documentation that's required in the operative report so that you can code for the correct procedure. And then, given the revision to so many of these codes, they did delete a couple of codes because now they're obsolete. They just don't make sense for the way that procedures are being done now. One thing that changed, and it really might only be this one change in some of these codes, but they just really found that the term mammoplasty was not current. And so they removed that word and they added the word breast or with implant in a lot of these descriptions. So some of these may not have huge revisions, but it's worth noting to make sure that those are checked. And then there's also a couple of category 3 codes for wound bacteria localization and treatment for you to take a look at. So in urology, there was really just one new code, and it was for the ablation of malignant prostate tissue using high intensity focused ultrasound. And really there was no code to describe this procedure. And so organizations have been reporting an unlisted CPT code up until 2021. So now it has its own code. And the AMA found that there is enough data to support that this method does ablate cancer, and they needed a code to describe this. There's one revised code, and really this was just removing some terms from the description because they found that it was just causing confusion with the antegrade urography code. And there are a few category 3 codes as well for a couple of things here. And I won't try to say every single one of those words, but cystourethoscopic anterior prostate category 3 code for drug delivery, and then also a valve pump insertion and intraurethral valve pump replacement. Okay, so otolaryngology, there are 3 codes. The first code may not be something that every organization would utilize, but it's a code that describes a less invasive repair of the nasal valve. And so it's an absorbable nasal implant repair. And so they found that they needed to distinguish this type of repair from code 30465, which involved more physician work. So 2 different methods for the repair. And so again, you would want to make sure that the documentation is clear so that you know which one to assign. And then I think the bigger one that a lot of organizations are going to be using is the dilation of eustachian tubes. So 69705 and 706 are new codes, and there had been no specific code to report dilation of the tubes before. So now we have 2 codes, and one reflects the bilateral dilation and the other reflects the unilateral. In audiology, there are 7 new codes, and they both really revolve around the vestibular evoked myogenic potential VEMP testing, and then the auditory evoked potentials, which is the AEPs. So if your organization or if your office practice performs any of these types of testing, then this would be one area in CPT that you would want to focus on and make sure you share this information with your providers that are doing this work so that they can see what the new codes are, and again, make sure that the documentation is reflecting these services accurately. And then as a result, they did delete a couple of codes because now they're no longer needed in the new code set. In ophthalmology, there was a couple of revised codes, one for ophthalmic ultrasound and the other for remote retinal imaging. And again, if your practice or organization performs these services, this would be some revisions that you'll want to share with the provider. 75613 specifically in that ultrasound section was developed to or revised to reflect a bilateral or unilateral ultrasound. So they've carved those out. And then they've also created some parent codes and some child codes then for the remote retinal imaging. So you might want to take a look at those. And then there's several category 3 codes for optical coherence tomography, iris prosthesis procedures, and trabeculostomy. So in OB, there's just one new code, and it's for the computer-aided mapping of the cervix. And it's an add-on code when this is performed in conjunction with a colposcopy. So now there's this code to identify this mapping piece that would be done in addition to the colposcopy. And then there's a couple of deleted codes, and they just found that these 2 codes weren't really necessary with the ability to report these procedures with other codes that have more updated methods and technology for their use. So then finally, we're into the lab and pathology section. And I did already talk about the COVID-19 testing and just wanted to separate that out from the other lab and pathology CPT code changes. So several things in this area. There's been some clarification around the drug classes listing and the therapeutic drug assay guidelines. So this would be a good section to read through, maybe share with your lab managers and ensure that you have the right code set up and that you have the correct codes for the types of tests that you're doing able to be selected, whether it's in your lab system or the EHR and your charge master. And then there's a gonadotropin stimulation panel that has been revised along with a new code added within that section. And then there's some molecular pathology procedures that have moved from tier 2 to tier 1. So that would be something to take a look at. And also there's a new code for genomic sequencing procedures for epilepsy. So if your lab is performing any of these types of testing, this would be the section to take a look at and make sure your charge master is updated. And then there's some new MAA codes, and there's some new category 1 codes that I've noted here. And then there's some administrative codes that I've listed. And again, there's the PLA codes. And these codes again are created based on the proprietary name of the test. And this entire list is located at the end of the pathology and laboratory section of CPT. So you can view the listing of codes, their descriptions, the brand names or the proprietary names. And there's 86 new codes that were added in 2021. So they definitely really focused on this section of CPT this year. And so when a PLA code exists, this is going to be considered the most specific code. And this is the one that should be reported rather than a category 1 or a category 3. Just wanted to reiterate that. So now we're done with really the bulk of the CPT book. But moving on to the evaluation and management, coding and documentation changes, simply because this we know is a big focus this year, but wanted to give you an overview of all of the CPT changes so that you can go back and reference those and take a look at what might be applicable to your organization. And that way you're ready to go on January 1st.
Thank you, Rachel, for that overview. Like she said, we did attend the CPT symposium, but this year was virtual, so that was a little bit trickier, but they did manage to get us all the same information, so that was nice. So now, without further ado, I know you guys have just been sitting on the edge of your seats waiting to hear about these 2021 E&M code changes. So by now, you've definitely heard these changes came about because CMS wanted to alleviate administrative burden, and they were just seeing with the EHR and the EMR so much erroneous documentation. Providers were simply complaining quite a bit about how that they were doing more paperwork than actually getting to spend time with their patients. So this initiative is actually titled Patients Over Paperwork. This is from CMS, which is Medicare, and I think it's very important for everyone to understand the distinction that CMS is Medicare, but CPT is put out by the AMA, the American Medical Association. So it's two different organizations, and that's why sometimes we have different sets of guidelines. I can think of global surgical packages one. CMS has their own guidelines for that, whereas CPT has their own guidelines as well. And sometimes it's very tricky to understand which one should I use when. So I'm going to try to clear some of that up for you. What we don't know right now is, will commercial Medicare Advantage or state Medicaid, follow suit with this? Because as of right now, like I said, these are guidelines put out by CMS. However, they are in the CPT code book. Right now, we have only received verification from Noridian that they're going to follow these documentation guidelines. That's the only one that we have in writing. So as of right now, we still will need to check with payers. But historically, what we know is that a majority of payers typically always fall in line with what Medicare does, because the policies are already written out, and why recreate the wheel? So what do we know? We know that these only are going to affect clinic or outpatient E&M visits. That's your 99202 through your 99215. 99201 has been deleted, and we'll get into those reasons why later. So it's only those clinic outpatient E&M visits. So maybe you just are going to throw away your 95 and 97 guidelines, or you're going to have a big bonfire and you're going to burn them. But just wait. You still need to hold on to those, because you're still going to have to know those if you're coding EDs, nursing home, inpatients, SNFs, etc. But again, what we do know is we think that they're using the E&M visits, the clinic outpatient ones, as sort of a guinea pig to see how it goes. And then they'll slowly incorporate all the other areas into that, because it just only makes sense. We're going to talk just a brief moment about documentation, because I think it's so important to understand that we really do need to have complete documentation that's going to support our ICD-10 diagnosis code and our CPT codes. What I always tell clients, and what I tell myself when I'm reviewing notes, is, could I defend this if I had to go to court? So I want to make sure that the documentation in that note can support the codes that I'm going to assign. And we really want to hone in on that specificity. That was really drilled into us for ICD-10. And now I want to make sure that we keep up with that. So maybe you have some tools at your job that can help with that, like the 3M encoder or Optum, or maybe you have a different sort of encoder. We want to always make sure we're educating our providers and our coding staff. We want to try to stay away from using those unspecified codes. And we want to remember that the code sets are updated each year. The most important piece of documentation is we want to prevent denials. Denials are costly for everybody, and the amount of time that it takes our business office or our billing staff to get that denial, to work that denial, to send it to somebody, to readmit it, to send it back, that's just a waste of everybody's time and money. So we want to try to prevent denials. And how are we going to do that? We want to get rid of clone notes. I mean, I could talk to you probably for 3 hours on Canon clone documentation, but nobody wants to hear that. But we want to get rid of all the cloning of notes that the EMR seems to have made quite popular, or made it easier to do. We want to remember that those new code sets come out. We want to stay away from upcoding, but we also want to stay away from downcoding. The OIG has come out many, many times and stated that downcoding is just as detrimental as upcoding. We want to get that highest specificity. I'm going to drill that into you. And we want to have teamwork. We want to make sure that our coding staff feels comfortable going to our providers, and that our providers feel comfortable talking to our coding staff. We want to be compliant. We obviously have to follow guidelines and those regulations that come from our governing boards. So if we have that incomplete, inaccurate documentation, so we want to see how thorough is our provider documentation. Our provider queries, does your EMR allow for those to be done electronically, or are you still doing what I did 20 years ago back at my first job, and I just walk down to the doctor's office and knock on the door and say, what did you mean here? And then do you have that communication? Do your coders and your CDI specialists work in the same area? Do your coders feel free to speak to your providers? Do your providers feel free to speak to your coding staff? All right, and then let's talk about the big elephant in the room. That's medical necessity. I did not make up this verbiage, but CMS does state that medical necessity is the overarching criteria when choosing your CPT code. And the reason that this came out, it came out approximately 7 years ago, was with the advent of the EMR and the EHR. We saw just a ton of notes that were 5, 6, 7 pages for like an ear infection. CMS became wise to that, and basically they're stating it's quality over quantity. They want you to say what you mean. They don't want you to check a bunch of boxes in your EHR so everything auto-populates, so it looks like you did a 10-point review of systems and a 10-point exam for something that maybe didn't necessarily need that. CMS has stated that it will continue to follow medical necessity, even with these 2021 guidelines. Medical necessity is still going to be the overarching criterion. And then the canon cloned. This is just a statement from CMS explaining when cloning occurs. We just really want to stay away from this. And again, the EHR has made it pretty simple to pull forward information. And what happens then is if the information was incorrect and you're pulling it forward and it's still incorrect and it just keeps getting pulled forward and it keeps maybe getting assigned a code on the claim form. And if it's incorrect, that's just not going to work for anybody. All right, so now let's dig into the dirty changes here. Effective January 2021, CMS will implement payment and coding changes to achieve additional burden reduction. Billing for visits will be simplified, and payment will vary primarily based on attributes that do not require separate complex documentation. That's straight out of CMS verbiage. CMS believes that the rise of EHR usage has led to note bloat. And simply stated, note bloat is what I said before, when we're checking all those boxes and everything auto-populates, and pretty soon we have this 5-page note for somebody that came in for a sore throat. And that current E&M office visit codes are outdated. They haven't been changed in almost 30 years. So when many of you maybe started in 1995, that was the advent of E&M coding. And then 2 years later, we know we got that little bit of an upgrade with the 97 guidelines where it changed the exam component. But can you believe they have not been touched since then? And that is crazy to think we've gone 30 years without even tweaking these. So starting January 2021, as part of the Patients Over Paperwork initiative, CMS is going to try to reduce that documentation burden in 2 ways. From now on, starting in January, you're going to be able to choose your code based on medical decision-making or total time. And we're going to get into each one of these, so don't worry. But again, medical necessity is going to be the overarching criterion, but we will be able to choose our code now based on medical decision-making or total time. They have eliminated that history component and they've eliminated that exam component. Now, that is not to say that your provider still shouldn't document that, but now they're stating that the provider can document a medically appropriate history and a medically appropriate exam. CMS is not telling you what that is. They are leaving that up to the provider. But obviously, you're going to want a little bit of meat in your note. So when the patient goes on to see another provider and that provider looks back at the note, we don't just have one simple statement in there saying, I spent 50 minutes with this patient. We're definitely going to want to see a little bit of meat. And given the high frequency of office evaluation and management visits, CMS indicates accounted for around 20% of the total charges for physician services. So any changes to the work RVUs associated with these codes are going to definitely have a significant impact on reimbursement for the professional services and potentially your physician compensation if you're basing that on productivity. And we're going to get into that in a little more narrow scope in the upcoming slides. So the 2021 E&M changes, the coding guidelines were created by the AMA in coordination with the CPT. So AMA, the American Medical Association, is the governing body of CPT. And then CMS, they came up with the guidelines, AMA and CPT adopted them, or I'm sorry, AMA and CPT came up with the guidelines, CMS adopted these revised guidelines as part of the final Medicare physician fee schedule. Now, we saw this going round and round in the proposed Medicare physician fee schedule, and now finally CMS has came out and adopted them in their final physician fee schedule. They believe that this is going to promote consistency, but this is a big caveat here, and this was a question that was raised earlier. CMS has not provided any expectations for the way in which the new guidelines will be audited. Therefore, you need to monitor CMS in your local MACs for direction. So the question that came in prior to this was, will there be an audit tool? And as far as I can tell you right now, there is no audit tool. And this was reinforced at the CPT Symposium. The speakers there that spoke about the E&M changes also stated that as of right now, there's no tool. Like prior, we had the Marshfield tool that a lot of payers would use to audit charts. As of right now, they don't have a tool and they don't have any expectations of how they're going to audit these notes. So a little summary of the revision. So we know that they've eliminated that history and physical element, but CMS has stated that providers should perform that medically appropriate history and exam. Again, they're not saying what that should look like, but obviously if the patient's in for a sore throat, it would behoove you to document, an ENT exam. It's going to allow physicians to choose whether their documentation is based on medical decision-making or time. Now, when we're referring to medical decision-making, it didn't change all that much from the 1995 version. So if you understand medical decision-making now, you're going to be just fine in 2021. You still have your 3 main buckets, and you still have to have an average of those 3 buckets. And there's still 4 different levels. We have our straightforward, our low, our moderate, and our high. It's just the same as it is in 1995. The time is what really changed. Right now, you have to state 50% of your total visit was spent in counseling and coordination of care, which led to the provider having to document 2 separate times, the amount of the entire visit and the amount that was counseling and coordination of care, and then that had to be 50% or more. Now it's going to be total time of that visit on that data service. And that's very important to remember. It can't be something you did 3 days before. It can't be something you did 2 days later. It's the total time spent on that data service. And we're definitely going to dive into that a little bit more, but please remember that. Now, the modifications that they did make to medical decision-making was they removed some of those ambiguous terms, and they gave you more information about like independent historian, what would count towards that. But other than that, they really didn't change it all that much. They did delete 99201, so that very top level, the easiest level to achieve in the new patient. They eliminated that because the medical decision-making for 99201 was identical to 99202, so they didn't need it. It would just have been a duplicative code, so they just got rid of it. And then they created a shorter prolonged service code. And I know there's a lot of hubbub going around about the prolonged service codes, and we're going to get into that in the next few slides. But they made a shorter one, so now it's only in 15-minute increments as opposed to that 30-minute increments that we have currently. All right, so now let's talk about if you're going to choose your code based on medical decision-making. Again, it's the same as in 1995. You have your same 3 buckets: your number and complexity of problems addressed, your amount and or complexity of data to be reviewed or analyzed, and then your table of risk. And you still have your 4 levels that you can choose from: your straightforward, your low, your moderate, and your high. But what they did now is they came out with this handy dandy grid that we're gonna have in the next couple slides. And I am giving you a link because it's very tiny handwriting. But they came out with this and it breaks it all down. So you should very easily be able to find where your documentation fits into that. And we did have a question prior to this, and I am going to show you it using the medical decision-making grid. What things we need to remember about decision-making: if it wasn't documented, it wasn't done. This is going to become very important now in 2021. Providers are going to have to If whatever they are performing, they're going to need to document, because we as coders are not in the room. And so if it wasn't documented, we have no idea if it was done. The purpose of the visit should always be clear. That's your chief complaint. And one of the major differences now in 2021 is that chief complaint can be documented by your ancillary staff, whereas prior it had to be documented by the provider. Now it can be done by the ancillary staff. And this next one is a huge one. Does the body of the note match the reason for the visit? And you would be surprised when we do chart reviews, this is probably the #1 thing we comment on. If the patient is coming in for a sore throat and a rash, I should see that in the review of systems and the exam. I should not see under review of systems everything normal, including skin. The patient has a rash, it should match the review of systems, and it should match the exam as well. You would be surprised how many times we see patient comes in with a plethora of things, and then review of systems and exam is completely normal because a checkbox was simply clicked and it auto-populated everything to be normal. There's no free text, which leads you to the next bullet. Are templates being utilized? And then that free text. So here's the main differences between medical decision-making in 2020 as opposed to 2021. So instead of saying number of diagnosis or management options, now it's stated number and complexity of problems addressed at the encounter. Amount and/or complexity of data to be reviewed. As you know, that's your labs and your x-rays. Remember how we get points for all that. Now it's stated as amount and/or complexity of data to be reviewed and analyzed. And then the table of risk, or the risk of complications and/or morbidity or mortality, is now risk of complications and/or morbidity or mortality of patient management. So as you can see, they really didn't make any major changes, which is good news. You don't have to learn anything new, which is always a bonus. And then that next slide is the MDM table. And I'm going to apologize right now because I know it's such tiny handwriting or tiny printing, but you can always just Google 2021 MDM table or AMA MDM table. And I do give you a link in the next couple of slides, but let's just look at this and I'll go through the example that someone sent in. So the question was, if I have a patient that's in for an acute visit with a URI, no other problems, but then they have a positive strep screen and they get a prescription, how would I code that based on medical decision making? Well, in your very first column, your number and/or complexity of problems addressed, that would fall under low because it's one acute, uncomplicated illness or injury. And then I'm gonna skip you right over to the third bucket, that risk of complication, because we know a prescription was given, so we can automatically check that as moderate. That's prescription drug management. And remember, it doesn't mean you have to get a new prescription. Prescription drug management is just as it states. So if the patient stays on the same amount of, say, lisinopril, the doctor doesn't change it, they still managed it. They still had to decide not to change it. So that still counts as prescription drug management. So in our case, they were prescribed amoxicillin. So over here, so now I have a low and I have a moderate. So whatever we choose in our middle bucket is going to be what decides our code. Well, this is going to be really come down to how well your providers document. Because if we get low, we have to have any combination of two from the following: the review of prior external notes from a unique source, the review of the result of each unique test, and the ordering of each unique test. So we ordered a strep, that's 1 point, and we went over the results of that. It was positive. If it was a rapid one and they waited around, that's 2, so we would be okay there. If the provider went back a visit in Epic, say, or whatever EMR you have, and they documented that they did that, that would be another point that would move us up into moderate. So we're waning between that 992 and 3 and that 992 and 4. Now, historically speaking, strep throat usually typically would probably be a 9, 9, 2, and 3, unless there was some extenuating circumstances, like the patient is, 90 some years old and also has pneumonia. Obviously that's going to be a lot higher complexity than if you're a healthy 8-year-old with a sore throat that turns out to be strep. But you can see the importance that we're going to have when we educate our providers to document what they're doing. I recently did a review, and I went in there, and the providers were just sure that they were being undercoded. And I sat down, and the one provider said, every time a patient comes in, I go back in Epic and I look at their prior visit, and if they've had any x-rays or anything, I even go back and I look at those. And I said, that's great. So where are you documenting that? And he goes, well, I don't. I just do it on every patient. Okay, well, there's our problem. The coders have no idea that you're going back and doing that. And if you don't put it in your documentation, then it just wasn't done. So now it's going to be very important for them to understand. If they go back and look at old notes, they need to put that. Now you get points for each individual test that you order, whereas prior it was you could have ordered 100 labs and you still only got 1 point. Now AMA is saying each unique test, order, or document contributes to the combination of 2 or combination of 3 in that middle bucket. When it says you have to get 3 from the following or 2 from the following. So that is good news there. So I would say in the example that was asked of us about the URI with the strep, I, without seeing any documentation, would probably say that that would meet the 213, which is pretty on par for 95 and 97. And if you go to the next slide, this just shows you again how, no, oh, I'll get there. No, you're good. Thank you, Amy. So this just shows you how you need to get 2 of the 3. It's just the exact same as in 1995. The AMA actually even came out and said the concept is unchanged from the current guidelines. So, and then that next slide, the blue one that Amy was on, that's just the link. If you can't find it in Google or anything, there is the link for the medical decision-making grid. Now, if we are going to choose our code based on time, this is probably the best thing that happened. It's the total time for the E&M service performed on that date of the encounter. Yeah, there you go. So this recognizes the importance of those non-face-to-face activities. I mean, how many of you coders have heard for years at your provider, I had to call somebody and I was on the phone with them for 5 minutes, or it took me forever to enter this into the EHR because I'm just not that good. Or it also removed the midpoint versus threshold by giving you exact ranges of times. And if you are going to code based on time, then it's basically saying that has nothing to do with MDM. So you're either going to code, if you're choosing to code based on MDM, time doesn't factor into it. And if you're choosing to code based on time, MDM, medical decision making, doesn't factor into that. They felt they needed to make that clear. So what activities can you count in time? There is a bunch. So as long as it's documented, let's always be clear on that. So on the date of service, preparing to see the patient. So that's like the providers I just recently saw. If you go back in your EHR, maybe you have paper records and you ordered them and you looked at prior visits, that time counts. Documenting that separately obtained history or exam, that medically appropriate history or exam. Counseling and educating the patient, the family, or the caregiver. Ordering meds, tests, or procedures. So this means if you have to call down, now probably a lot of providers don't do this on their own, but say they had to call down to radiology to set up a mammogram, or they had to call lab because they wanted this patient to get a A1C right away, and they were on hold however much time. As long as they document that, they can go towards that total time. But what you want to make sure you're not doing is double dipping. So while I'm on hold with radiology, I'm also looking at my next patient's prior visit. I can't count that time for both patients. The time can only count for one patient. We don't want to run into any double dipping. And where you're going to get in trouble with this is if someone comes in to audit you and you're coding all yours based on time, and they add up one of your day's visits and it comes to 25 hours. Obviously, there's only 24 hours in a day and you're not working all 24 of those. So that would definitely put you as an outlier and put up a red flag for you to be audited. Referring and communicating with other healthcare professionals, that's where you could be on hold for a while, or you could be speaking on this. Oncology is a great one for this, because they may have to call rad oncology and they could be on hold for a while, or they could be speaking to the rad onc provider for a while. Documenting clinical information in the EHR or other health record. We all have that one provider who struggles with the EMR, and now they will be able to count that time towards something. Independently interpreting results if you're not separately reporting it with another code, and then care coordination if you're not separately reporting that with another CPT code. So I've given this presentation a couple times, and this question has come up many times, so I actually put it into my presentation. So what constitutes an other healthcare professional? Well, in 2013, the AMA established their definition for a qualified health professional, or a QHP, in terms of which providers may report medical services. A physician or other QHP is an individual who is qualified by education, training, licensure, and facility privileging when applicable, who performs a professional service within his or her scope of practice and independently reports that professional service. So depending on your state scope and your licensing, and obviously CMS guidelines, it would be your nurse practitioners, your CNSs, your PAs, your certified nurse midwives, your CRNAs, clinical social worker, and physical therapist. And this isn't an all-inclusive list, but these are other people who would technically be QHPs. All right, the next slide is just showing you, and I know we're getting up there on time, and I am so sorry. So the next slide is just showing you the difference between 2020 times for new patient and then the times for 2021. And I really want to get into prolonged care. So I think, and then the slide after that is the established and the new times. So prolonged services. They came up with this code 99417, and it's an add-on code. Some things to remember about this code is it can only be used on 99205 and 99215, the two highest level codes. And in order to assign this, you have to have 15 minutes extra. It can't be the midpoint. It can't be like 8 minutes or so. So what happened was CPT had a disagreement with CMS about this prolonged care code, because CPT states you can start the 15 minutes when you meet the lowest time point, whereas CMS said, no, it's when you reach the maximum time is when you would start your prolonged service. So the next two slides are just two grids, and they are different. The first grid is from CPT. The next grid is from CMS. So about 2-3 days ago, we get the final rule, and surprise, you can go to the next slide, please. The CMS did not agree with the AMA and CPT for their final descriptor for prolonged code 99417, so they came out with their own code, G2212. So now you're going to have to assign prolonged codes based on payers. 99417 will not go on any of your Medicare claims. That you'll use G2212. And in order to use G2212, you have to start at the maximum time of 215 and 205. For 99417, you can start at the minimum time. And I know that is so confusing. It's still unknown. You can forward the slides, please. It's still unknown what code, one more, that private payers will prefer, and facilities, you may want to adopt policies as you speak to payers and get it down in writing. That way, if you're ever audited, you can say, I coded it this way because of XYZ told me from ABC insurance company that this is how we had to do it. The next few slides are about the conversion factor, and maybe this won't relate to you at your facility, but generally speaking, professional services are determined by multiplying the applicable RVU times the conversion factor. So in 2020, the conversion factor was 3609. In 2021, it went to 3241, which is about a 10% decrease in that conversion factor. So what does this mean? This means if you're primary care or a specialty that you see just a ton of office visits, the increase is probably going to be, you know, substantially offset the decreased conversion factor depending on your, you know, payer mix, etc. Excuse me. But specialties that have a higher percentage of activity in procedural codes, think like dermatology with fewer office visits, you'll likely experience a significant decline in your Medicare reimbursement as the conversion factor went straight across the board and not just for those E&M codes. And then the next, yep, one more is another grid with the final rule. Okay, so what can I'm just going to skip all the way to the last two slides. What should your facility do? You need to update, revise your templates and your macros. We don't typically recommend using templates, but we know it happens. So we want to update them to eliminate the need for anything that doesn't need to be on there. We want to eliminate that copy and paste functionality. We want to get that medical necessity in there. We want to revise our templates to focus on that updated medical decision-making verbiage and the time components. We want to get that 99201 off of there. And we want to speak to our EMR vendors on developing templates that can maybe help you track your time for certain things that you're doing, and then that way help you pick your code assignment. Thank you so much for listening. I apologize that we went over. There's just so much information. But if you have any questions, the questions that were asked in the chat, we will get the answers to and get them sent out in a mass email. Otherwise, you have my information, you have Rachel's information. Please feel free to email, call us with any additional questions. And again, thank you so much for giving us your time. We appreciate it. And I'm so sorry that it went over. I could talk to you guys for days, but thank you.
Thanks, everyone.